welcome back. Today we are talking everything trauma. I've done a 4 months course over 10 days, or 8, doesn't matter, last fall and winter. And I was thinking, let's just recap the things that I learned that I wanted to share with other starting trauma therapists, or even if you're a more advanced therapist, and it will probably also be good for memory consolidation, right? Why did I chose this course? Like, I'm in a trajectory to get a full registration for CBT, and within that there's freedom of choice to do follow-up courses. And I was really happy that this was an option because often I've noticed that, especially with trauma therapies, you often have a course focus completely on a certain technique, an EMDR course, a rescripting course, an exposure course. I can imagine that in other countries it will be focused more on trauma CBT. But what appealed to me in this course is that it is really was a broad course about trauma. So we talked a lot about what is trauma, what is normal processing, how can you organize trauma treatment, which options for treatment are there? How can you choose? What is the overlap with personality disorders? So it was a really broad kind of overview about everything trauma. And I noticed that over the last couple of years, I really love doing trauma therapy. Of course, you don't wish suffering on anyone, but I feel like with certain doctors who might be happy when they can do a certain procedure or really interested in something, I feel like that with trauma treatment. But I did notice that sometimes I was lacking a bit of confidence, especially when I was treating clients for trauma who showed more complex trauma, like c-PTSD, or where there was like a lot of trauma. And yeah, I hope that was my hope up front, that at least this course would help me to feel more confident in my skills. So yeah, it definitely met up to that expectation. So I'm really happy about that. I learned much more than I even expected. And today we are going to all of these topics. I asked ChatGPT, can you make this in like a nice image? It delivered. There are like small grammar slibberishes in it that I'm like, I don't think that's actually an English word, but okay. You can see it more like in the beginning, we're going to talk more about what is normal processing, how does trauma look like in the brain. Then we're going to talk more about how do you organize trauma treatment and certain discussions that have happened in that debate. Then we are talking more about things I've learned in the delivery of certain trauma therapies. And last, we are talking about some other things like dissociation or the overlap with personality disorders. So yeah, let's get started. So the first thing that I think is really important sometimes to remember is that most people are actually capable of processing impactful situations in a natural way, meaning that the brain is able to process what happened. People don't develop trauma symptoms or PTSD and they don't need treatment. It sounds like duh, but as a therapist, you often see people who come in with issues, which also kind of shapes the world the image you have of trauma. So for me, it was really helpful to learn about normal processing. Like, what have we learned from research, from practice? Like, how do people actually do that? And what is normal? So in this overview, you can kind of see what is normal in the way the emotional distress kind of develops throughout time after an impactful event. So for our brain, it takes around 4 to 6 weeks to naturally process an impactful event. And especially in the weeks after it is very normal to experience high levels of emotional distress when you think back about the event, when you talk about it, and you kind of relive it. That is normal. That doesn't mean that someone is developing PTSD. That doesn't mean that we have to intervene or start treatment already, that's actually very normal. And like what you see in, okay, so it is normal that it takes around 4 to 6 weeks, but how does this actually work? And you can kind of see here a clear image of what healthy processing often looks like. It is kind of a combination of reliving what happened by having nightmares about it, by having constant flashbacks, by talking about it, writing about it, discussing it, looking up information, while at the same time also have periods of avoidance or distraction. So people also are able to take care of themselves, do their household, go to their jobs eventually, participate in hobbies, are able to focus on the conversation with someone else. So it is healthy for the brain to have kind of this loop between the two of them. So that might also be good to know that if you have gone through something, that it is completely normal in the weeks after that to have reliving symptoms, to have flashbacks, to have nightmares, and that also it is really good to focus on distraction, on keeping up a normal rhythm, on doing the things you did before the impactful event. And by doing that, the brain is able to process it more naturally. There are a lot of different things that processes that kind of help with that. I'm not going to talk in depth in here, but think about like this actually helps to get stimulus discrimination again, so that someone by processing starts to see like, hey, my attacker was a danger, but not all men or not all people. Or for example, hey, I hear a loud noise, I relive it, but hey, this is actually not the sign that someone is shooting. So that's happening in their brain, like the stimulus discrimination, but also association processes, that the story gets more embedded into the narrative, all kind of brain processes that are happening. But in the core, if you think about what is happening with normal processing, just remember that it is healthy to have this picture. And I think this can also help you to give psychoeducation when you have a client in your chair who just gone through an impactful event and might want to start treatment immediately. We're going to talk a bit more about that at the second point. But first, I think this was like one of the first big realizations that I had throughout this course. Most human brains are perfectly fine and capable of processing impactful events. And most cases, people don't develop PTSD symptoms. Around 5 to 15% develop PTSD symptoms after criteria A trauma, which also means that 80 to 90% of people don't. So yeah, that is more about normal processing. Okay, the second part is then an interesting question because, okay, if we have that knowledge, but what do we do with people who have just gone through a very impactful situation? That can be on a personal level, but it can also be on a company level, on a society level, after, for example, natural disasters or a mass shooting. Like, is it smart to directly start trauma therapy? What do you actually do? This might also not be really the population that you often see as a therapist, because people often come in again after those 4 to 6 weeks when they've developed trauma. But you can also be in a therapy process and someone has a car accident, for example, or there is a natural disaster happening. Then it's still good to apply the watchful waiting approach. So if you're a psychologist, the watchful waiting actually means what it says, that you do have an eye for what is happening, but you allow the brain to start processing it on its own. And you don't want to intervene too soon. In the past, there were kind of thoughts about like you can't do harm, just start trauma therapy. But that actually takes away the natural processing of the brain. Like, you want to give the brain a chance. So watchful waiting means that in the first 4 to 6 weeks in general, there are several things to do. First is that a supporting context is key in helping that natural processing in happening. So by providing, you listen to someone, you focus on day-to-day structure, you kind of ensure that someone is surrounded by, for them, safe people. So it is really about going back to the basics. You listen, you provide structure, and that's that. The other thing that you can do is provide psychoeducation. Just explain what is happening in the brain. You can even draw the pictures that I discussed at the first point to kind of explain, hey, like, this is normal, and it's normal to have symptoms, it's normal to relive things, it's actually beneficial, your brain is going to the natural processing, I am here to listen, and we're gonna focus on your day-to-day structure. And mostly just comforting that it is really normal to experience symptoms in weeks after that. The watchful waiting also means is to kind of ask people for these levels. Because if you want to get a graphic like this one, where you can kind of point, that's the watchful waiting, where you can observe, hey, what does the SUD, so like the subject unit of emotional distress, like the levels of emotional distress when thinking about the event, where are they? And you hope to kind of see that with time it lowers, and that actually means that the brain is developing in a healthy way. In the DSM, we would call this an acute stress disorder. So you also are not allowed, or it's not possible to diagnose someone with PTSD because of this process. Like, most people, 80 to 90% of the brains are fine by processing on its own. And if you are close to them, just provide comfort, make sure that someone has a day-to-day structure, has a support network, explain what's going on, and use the watchful waiting with like measuring the emotional distress. And you can literally do that. You don't have to like go to like the how do you say it, what you sometimes do with EMDR or with like prolonged exposure, that you have to let them focus on the worst part. You just ask them, hey, if you now think back about the event, where is your how high is your emotional distress on a level from 0 to 10? Yeah, I found this picture. I was like, hey, that might sums it up a bit. Like, the brain inside is saying, hey, give me a bit of time. You as a therapist might also feel like, oh, but we can start EMDR, we can start doing this and that. No, let's give the brain a proper chance of doing this in a natural way. Okay, if we know that, there are, of course, exceptions. And that's what this slide is more about. Like, okay, but is that true for every client? Like, when to intervene before those 4 to 6 weeks? Because there are cases where it could be beneficial to start trauma treatment earlier. And like the teacher of my course explained it a bit like this. Like, if we know that this is how normal processing looks like, and you first want to watchful wait. An indication that PTSD might be developing is when, even after, like, say, 3 to 4 weeks, the SUD, or the emotional distress, is still very high or has even heightened over time. So in the 2 weeks after it, it is very normal to have those 8 to 10 range. But if that is still there after 3 to 4 weeks, it could be a clear indication that starting sooner can be beneficial. And then you can start trauma treatment earlier. So that's also the watchful waiting. You don't do that only to see the graphic and show it to your client. It is really to monitor, hey, okay, can we see like when is the SAT not changing enough? And there is not like a very clear formulation, like with this number, you have to start it at that week. But you can kind of feel that happening and also probably see it with your client if the anxiety only gets worse. But also, for example, if someone is really avoiding things, has lost control of their day-to-day structure, you can kind of see that someone has gotten really stuck in that reliving experience, or the complete opposite and more in that avoidance experience. So yeah, still, I think the general message is don't start too soon. Don't get every therapeutic toolkit out of your backpack, and just give it a bit of rest. And otherwise, if you still see the emotional distress being very high, start sooner. And I think it's interesting in this context also to know a bit more about which groups to look out for a bit more cautious, in a way that we know that PTSD numbers are higher. Like the one that stands out the most is sexual abuse. We know that rape survivors, 50% develop PTSD. So you kind of know that if you have a person in your environment or a client that has experienced sexual assault in that way, that there is a high chance. However, when I heard this number, yes, it is very high, but it was also kind of an eye-opener that even half of the humans who go to such an intrusive, horrific event are still able to kind of process that in a normal way without developing trauma symptoms. And I think that's actually quite remarkable of the brain, because, yeah, I think that, again, if you picture about what sexual assault actually entails, it is not weird, to say the least, that people develop health symptoms or mental health symptoms afterwards. But just know that that's a risk factor. And the other predictive factor that has come out of research is dissociation during or directly after the traumatic event, and tonic immobilization. So that dissociation, but also that you feel that you can't move or that you're kind of locked in your body, which we also see a lot in sexual assault, but also, for example, people who have just gone through a car accident and are waiting for the ambulance. So when someone really describes that dissociation or tonic immobilization during or directly after the traumatic event, just be on the lookout a bit more, because it is a predictor of PTSD symptoms. Then the third thing I wanted to share with you is that, okay, but if there is a traumatic memory, and so someone comes into treatment, how can you kind of understand when it is a processed event and when it is more still an active trauma? And when you look at the trauma file or the memory file of a traumatic event, it shows that these different elements are all very fragmented. So here you can see, like, when the memory file is active, it's often very strongly sensory wise. So people can see it again, hear it again, smell things. Besides, it has often a strong cognitive component, such as I am powerless, I'm still in danger, other people can't be trusted, the world is a dangerous place. It has a strong emotional, so people can feel extreme anxiety, sadness, shame, guilt, disgust. Another one is that it is often dissociative, which means that there is not like a clear sense of time. It's not like there is a clear starting point and end point. Often people only have like a small blimp of what happened, and the rest is kind of also dissociated. And people sometimes also don't have access to the rest of it. A loss of time. So when the trauma memory is active, you can see it in clients that it is not something that they see as it happened in the past. It feels like it is still happening, or is happening actually right now when they're talking to you. It also has a detached aspect in a way that it makes people feel like they are alone. There's a barrier between them and the world and a certain disconnect. And the last is bodily, which is often the higher arousal state. And talking about it like this, I think it's interesting that you can also see the clear overlap with the DSM-5 criteria. And you can see that in this picture. I'm not going to go to all the trauma or through the different DSM-5 criteria, but it shows that the actual diagnosis is also made up of how it actually looks like in the treatment and what you can see when you're talking to someone. Another thing that I found very interesting is that I wasn't that aware, but when you think of it, it does make sense from what you also see with clients in your therapy room, is the part that it is also often very detached from the narrative. So when something is processed, people kind of have given meaning to it in the context of their life. It is embedded in their life story. But with traumatic events, they are often kind of separate. So people can have their own life, can even live a life that seems to be quite okay. And what happened is kind of swarming somewhere else. It is not really embedded in the life story. And it's often also, I think, the part where you can literally feel that when someone is talking about it, it is as if they're talking about someone else's story. It's like they are narrating a book or talking about someone else. It doesn't feel that there is a clear connect between, I would say, the brain and the body, but also between like what happened and their own life story. And the last one is more also a part of what is happening on a brain level, and that is that it is detached from the right meaning. What we know from like healthy processing is that when something very impactful happens, there's a lot of data coming into the system, a lot of information through your senses. You see a lot, hear a lot, smell a lot. It is overwhelming. And that's the first thing that the brain processes. In healthy processing, afterwards, it goes through kind of this more conceptually driven memory, where it is embedded in a narrative. It is fitted with the right meaning, such as, oh my God, this is awful, but hey, the attacker had some issues. It doesn't say anything about me or other people. When people can kind of see, hey, this was a once in a lifetime risk or happening like with a natural disaster or when you're in a shooting. But when it is not fitted in the right meaning, you have an issue. And that's often what happens when the natural processing of the brain doesn't work properly, is that it kind of skips this step. So when the traumatic memory or the event is processed and stored, it is in a very data-driven way. So you have this long-term memory, which you can see also in this picture. And what you can see is that if a client comes to you and you're doubting, hey, is this processed or not? See how people talk about it. If it is like in a way that when you talk about it, it is in a very senses, a very driven, data-driven way, that's a clear sign that it is properly not processed healthy, which you also see in the trauma symptoms, right? That with the flashbacks, with like the high arousal. And when it is more in a conceptual driven way, so people still feel some emotions, but it has like a clear start and end, it is embedded in the life narrative, you can kind of start to distinguish, hey, okay, this is of course awful that happened, it has a clear impact on you, only it doesn't sound as if it needs active trauma treatment. I think it's kind of cool to understand that the goal of trauma treatment is to bring all these aspects together so that they are attached and it is not a detached, I would say, kind of a mess in the long-term memory anymore. So that people have a clear start and an end of the event. It is much more in a conceptually driven way, not that high in senses. People can put fitting meaning to it. It is embedded in a life history and narrative. So it becomes like of a clear package in the long-term brain. The fourth part is more about stabilisation. Is this mandatory, yes or no? This has been a debate or discussion that was especially heated, I think, a bit before our time, if you're also more of a starting therapist with trauma. But I would say from the 2010s to 2020s, this was a very hot topic, especially in the Netherlands, but I assume it has had a worldwide impact. And to understand a bit better, like, what was the debate actually about, I think it is sometimes good to remember that, especially when we talk about trauma treatment, until the 90s, thousands, there were barely successful treatments. And for a very long period of time, the best way to work with trauma was to kind of cover it, to learn people emotion regulation strategies, but to bury it. And by now, we have so much more options for certain trauma therapy. However, I think that kind of need to stabilize and to use to learn emotion regulation tools to kind of work with trauma, with the symptoms of it, is kind of deeply ingrained in a lot of therapists, especially also from a bit of the older generations. And I think it is good that, like, with a new wave of trauma treatments and research, the question has been risen, like, is it needed? Because in the Netherlands, it was almost always that people who had gone through more complex trauma and had complex PTSD, that before you started processing the trauma, you had to have gone through like a stabilisation course where you learn more emotional regulation skills, where you learn how to deal with trauma symptoms. And afterwards, if you pass that, you can start doing trauma treatment. And I think that is more the old way, when therapists are like, clients need to be stable first, and then you can start trauma treatment. And the standard protocol was for a long time that it was a clear phase, that you start with stabilization and after that comes the processing. That was also part of like the protocols of the recommendations worldwide. And then more the new sound came, where from research it showed that it was actually not needed. And this whole new group of therapists were like, no, stabilization is not needed. And furthermore, the trauma treatment itself is the stabilization. People get stable through trauma treatment, not the other way around. And there has been like fighting both ways. And I would say by now, most clinicians work somewhere in the middle, where you start with trauma treatment. That's, I would say, the golden rule. However, in some cases, stabilization is needed. Stabilization is the only thing that is accessible at that moment, and you make that as short as possible, as long as needed. So yeah, I think with debates like this, it is good that you have like certain camps, I would say, like pros, cons, and people who debate that. But I think for most clinicians, they work somewhere in the middle, because in an ideal situation, you start immediately with trauma treatment. In certain cases, that's not possible, or someone doesn't want that. And then it is helpful to have at least certain stabilization tools in your toolkit. So yeah, curious to hear what you think of this and how you practice this. And the teacher of the course that I had actually proposed a bit of a different symptom, because I think the pro of the phase-based approach where you had stabilization first and processing after is that it kind of gives a tool for therapists also to know, hey, what are we doing this session? Where are we in the process? Because when we are talking about complex PTSD, there's often a lot happening. People have issues close to the trauma, but there can also be all kind of issues in the system. Someone might have financial issues, addictions, all kind of other things that are happening. And it is not that easy to stay on track. So they kind of came up with this figure, and that's the fifth thing I wanted to share with you, and that's called the intervention circle. So it is not like a phase-based in time, you just have different components. And what I really like about this model is that you can clearly see in the middle what is the core of trauma treatment. It is processing. It is not stabilizing. It is not learning emotional regulation tools. In the core, it is processing through whatever trauma therapy is most known in your country. But in the Netherlands, the three that are most commonly used are EMDR, imaginary exposure or prolonged exposure, and imaginary rescripting. So core of the treatment is focused on that. Especially when you are treating clients with c-PTSD or with normal PTSD and a personality disorder, is that it helps to kind of get an overview of the other things that you are doing besides the processing therapy. Here you can see all kind of examples, but like processing, again, is the core. A part of trauma therapy is psychoeducation. So this is when you are in this block or part of the circle, you can kind of give explanation about what is trauma, what is happening in the brain, but also explaining the case conceptualization. Often when it is about c-PTSD, it is also very important to let people learn more about basic emotional needs, what is normal development, about things like loyalty or excessive guilt. If you are providing all of that, you're in the psychoeducation part. Then we have a practical part, which is more about the basics, the day-to-day things, sleep, managing a household, eating enough, having a day-to-day structure. Then the emotion regulation part. So that's the yellow here. And in the old way, that would always come before the processing. Here it is just part of the circle. And I do think that because by now we know that stabilization is not needed, it is also not that integrated into trauma-based courses anymore. So if you learn about EMDR, if you learn about imaginary exposure, prolonged exposure, you don't learn a lot about stabilization. So for me, it was also really nice to get several tools, like how do you actually do that? And when we talk about emotion regulation skills, think of relaxation exercises, grounding, the management of anger, hobbies, research development installation. If you work with EMDR, that's all part of the emotion regulation part. It could be that certain sessions or part of sessions you are working more with the system. You might have conversations with family, with partners, with children. And when it is needed, it can also be more that the interventions are based on family treatment. And the last is the integration part. That used to be the last part of the phase-based approach, where you had like stabilization, reprocessing, and integration. And this is really the part where people work on, okay, now I have processed all these traumas. It has become embedded in my life narrative. But often that also raises questions like, who am I? Or what do I want with relationships now? What do I want with work, with a job? How do I actually start living life now I don't have to be in survival mode all the time? That's much more part of the integration phase, where you really talk about things like that. It can also be talking about sexuality. How do you engage in that again? This can be work of a trauma therapist, but often this can also be done by clients on their own or by more social workers. So yeah, I do think that this can be a nice way of organizing that is better fitting with the research and clinical practice knowledge that we have today in 2025. Then we are actually going to the sixth point. Like the first half of what I discussed was also the first half of the course. So it was really on what is trauma, how can you organize that. We talked about stabilisation more in depth in the course, like the different techniques that you could use. But then you actually want to start trauma therapy. And I learned also that there is much more than that I knew of. And I think one of the interesting therapies that were kind of new to me were therapies that focus more on the narrative, which are testimony therapy and narrative exposure therapy. And what is nice about these strategies is that they are seen as more global trauma processing. So you don't have to dig very deeply into very specific events, such as with EMDR, prolonged exposure, or imaginary rescripting. In narrative exposure therapy, there is a bit of that, but in the base, it is really focused on the narrative and embedding what happened within that. So in narrative exposure therapy, there's also a lot of focus on positive things that happened in your life. And here you can read a bit more about testimony therapy. I personally haven't worked with this yet, but I do remember several clients where you felt that real trauma therapy was not the right fit, and it was much more in talking through what happened. And I think in hindsight that had aspects of this testimony therapy, but this actually developed in South America, specifically, I think it is Chile, after political prisoners there started to talk about what happened during political trials. And they found out that that was really helpful to kind of talk about what happened in a very clear and clean and structured way. So not really in depth about emotions, but kind of factual, like you would expect in law enforcement. Yeah, you can read a bit more about that here. And the other part is narrative exposure therapy. That's actually a very beautiful therapy, and I would love to learn more about that in the future. But it is actually developed within refugee camps and in war environments. And you can kind of see that throughout like the core of the treatment, which I think is so beautiful, that at the start you kind of make a line which is often with whatever is available, and then you use objects out of the environment to represent certain things. And you can also understand that the things that are used were often also available within refugee camps. So it has 3 phases. The first one is building that lifeline, and people can place a stone, which is representative for negative or traumatic events. They can also alter the size of the stone. Flower, which indicates positive events. You have candles for those who have died and where you are mourning, and branch. And the branch is an interesting part, which actually means the offense, so that you have done something in which you were more in the role of the offender. And placing that line can already be like a bonding experience, and that can help processing trauma in the narrative way. And phase 2 is more focused on processing the stones, I would say, but also things where you might have been in the offensive role. And that looks a bit more like prolonged exposure. And the phase 3 is integrated. And eventually people also really have like a document or a book, which we call the narrative. There's much more to explain about this, and I would definitely recommend reading more into this, because it is kind of, I think, a beautiful way in focusing on the narrative because it also includes positive things. It has space for when you have been more in the offending role, and it has a very clear protocol, I would say. Yeah, so might be new for you as well, but definitely something to check out. I suspect that if you work within the trauma field, that you probably work with one of the more specific trauma techniques that really focus on a certain event within a session. You try to process that. Sometimes there is a trauma list you work through. And in the Netherlands, like a prolonged exposure, EMDR and imaginary rescripting are the largest. But for example, in the States, trauma cognitive behavioral therapy is much larger. I know that family systems is also internal family systems. I don't know if you would recall that as a trauma therapy, but I suspect that it has some elements of that as well. Yeah, we talked several days, like we had a day of EMDR, we had a day of imaginary exposure, there was a day of imaginary rescripting. It is good to mention that it is not that if we did this course that at the end you can say, hey, I can do EMDR. You actually have to have like a basic training in that separately. But it was much more to kind of understand EMDR in the context of all these trauma therapies and to get an understanding of what it actually is. And the other part is that I use EMDR mostly as trauma treatment option or imaginary rescripting. And prolonged exposure, I had that like 6 or 7 years ago in the basic CBT course, but afterwards I barely used it. Actually meaning that I didn't use it at all. And one of the reasons was that I felt that what I remembered of it was that it was kind of brutal work. Like you really have to relive almost the trauma with the client. It is really focused on the details again and again. You have to push, and that it was kind of hard work. And in hindsight, I think that it also had to do with me being like a complete new therapist, that you might not have felt the basic level of training to even work in that way. But now we are doing it, and I noticed the progress that actually it is not as scary as I assumed, and it is also not that difficult. And certain tips that really helped me are listed here. I must say, when making this video, I hope that by now I would have used it more, but you probably also have your go-tos, and for me it stays EMDR and imaginary rescripting. But at least I know that if I have a client who wants this kind of treatment, or when it would be indicated, I know how to do it and I feel comfortable doing it. So one of the tips that our teacher taught us is that in the first exposure round, really try to identify the hotspots, and that it is really okay to ask for the emotional distress a bit more often. As a therapist, you might feel that then you are blocking the experience or the process too much, which is not the case. And it actually really helps you to be able to like focus on where do we need to focus the exposure mostly on. And that's actually the second thing, to just repeat the hotspots over and over and over again. And when there are many events, you can also address multiple hotspots back to back, or you can focus on those with the highest emotional stress levels. Another thing that helped me is that what I've noticed, that if I've done this procedure, that sometimes you can kind of feel that clients are stuck within the traumatic memory file. And sometimes it is good when people have like a small amount of silence, because you feel that someone is processing. But what to do once you feel like, hey, the person is actually starting to maybe be in it too much, or kind of stops talking, is just to kindly ask like, hey, not hey, and what happened after? So that you can kind of get the train going again. Okay, and what happened after? And people start to talk again. When this is especially a good technique is when there is a lot of anxiety to process trauma, and when you suspect avoidance. Like with EMDR, of course, there are also all kind of techniques to kind of minimize this from happening. But I feel like there are still possible ways to do it, and even quite easily. And with imaginary or prolonged exposure, it's much harder for clients to avoid. And when you suspect avoidance, you can also intervene, I would say, quicker or more efficiently by asking about the sensory stimuli to keep the image vivid. Like, what do you see? What do you hear? By slowing down the pace of storytelling. So when someone is just flying through the traumatic event, you can kind of roll it back a bit and ask them about more details. And in general, it is very important during prolonged exposure to stay off track, just as with EMDR, in a way that if you are intervening, don't ask for cognitive details too much. Keep it to the senses, because when you start to ask cognitive questions, that needs a different part of the brain, and someone can actually jump out of the processing, and that's not what you want. You want that senses brain. Again, if we think back about more the start of this video, the very data driven, that's also what you need for processing. So yeah, if you work with prolonged exposure, that's already great. And I think if you, just like me, had a bit of hesitation to use it, it is quite easy to freshen up again and to kind of also see that it is cool to notice that you've learned a lot over the years, and that certain things that you might concluded 5 or even longer, 5 years ago or longer, are not necessarily true on this date. So the other thing that we worked on was imaginary rescripting, and how can you make that effective. Of course, we talked about several things, but for me it was really helpful to learn a bit more on how can I actually make it more efficient. So how can I get a bit more structure within the rescripting, because I did use these phases that we describe here, but within those phases, especially if you have a creative associative brain as me as well, you can kind of get lost in that and like forget about like the actually point or the actual emotional need that you are trying to meet within the rescription. So to have a short recap with rescripting, the idea is that you can actually go back in time by imaginative power, like you can kind of let clients describe what happened, and then there is an intervention from an adult within the same traumatic memory file. If it is possible, it is the adult client. But in a lot of cases, especially at the beginning, it will be you as a therapist who will step into this situation to help the younger client. And this can be, it's often focused on two things. First, to stop the perpetrator or to stop the abuser, to stop the bad thing from happening. And the other part is to bring safety to the child. And that can, of course, look like a lot of different things. And then the last phase is that you can kind of, at the end of the second phase, you rewind and you let clients describe what happened within the new memory from the child perspective. So, for example, someone starts talking, okay, I see my father, but adult me is there now as well. And adult me says to my father that it needs to stop and that it is not okay. Okay, and that integrates kind of that rescripting. So how can you might also make it a bit more structured, besides using those 3 phases, is to keep the questions that you ask your client to kind of a minimum. And I know my teacher really used this like frequently after each other, time after time, to get a lot of structure into the session. And it does make it more efficient. So you ask like, what do you see? What do you feel? What do you think? What do you want to do? For example, I see that my father wants to hit my mother. What do you feel? Very scared, very powerless. What do you think? I need to save my mother. What do you want to do? I want to stop my father. And that's what you then actually do as the therapist. And you repeat this process until the perpetrator is stopped, until the child is safe and the needs are met. Another thing that helped me to learn more about is that it is very easy to forget the other parent. So there is often in abusive situations the abusive parent and the enabling parent. And how important it is to also incorporate the more enabling parent or the parent who doesn't know what is happening within the rescriptions. It can be that clients feel a lot of hesitation towards that because they want to protect the other parent, but there is often also the healing part. And that it can really be helpful to include both. And you can do this easily by saying, hey, I want your mother to come into this memory as well. And people are often quite easy in that they can imagine that. And the last thing is that it is important to be aware of the line between meeting the needs and altering the trauma, because it is not some hocus pocus and we make everything happy. You can't imagine suddenly that your father never abused you or that he has become a wonderful parent. That's not necessarily the point. And walking this line with this example, it is very clear, but sometimes it is not that easy to kind of pinpoint when you are crossing the line or when the clients want to cross the line, because it does make sense that a child says, yeah, I just want a different parent. But yeah, it is important to be cautious of that as well. I think in general, rescripting is such a cool way of processing trauma. And if you also are a bit like me, I am still very learning with rescripting as well, how to effectively talk back to the perpetrator or to the abuser. But I might gonna make another video about that later on, because otherwise this video will become hours long. I think we are already on 1 hour maybe. So yeah, we only have a small part left. So bear with me. Another part of trauma treatment, I think, which is important to learn more about, is dissociation. This was also the part where I felt like, hey, I actually want to learn more about trauma, because how can we properly deal with this? You see it when you start working more with c-PTSD, you see it happening more also during EMDR. And it did make me question like, hey, am I already equipped enough to handle this? And one of the first things that really made me be like, yeah, that's like a light bulb moment, is that dissociation is literally the opposite of association. Association is what you want in trauma treatment, especially in things like EMDR. It is so essential. And dissociation is kind of literally the opposite of it. And if you want to manage dissociation, there are several techniques. However, I think that when it comes to dissociation, there's also still a lot of controversy or debate going on how to handle that properly. Like, do you intervene with, for example, grounding? engaging in working memory tasks, like altering the trauma by saying, hey, you only have to tell the story in 30 seconds. They are listed here. But there are also trauma therapists who say no, because if you do that, you are still kind of reinforcing this coping mechanism. And the best thing is to not deal with it in that way, just to say, hey, I see that you're dissociating now. I will be waiting here until you are ready to continue. And then you just sit there and wait. And this can mean a minute. This can also mean that you're sitting there 20 minutes. In the long run, this might help clients better to get out of their dissociation and not reinforcing it. But as you can imagine, this is also the part, I think, where maybe 10 or 20 years from now, there are more guidelines on what is best to do. But for now, I often lean more towards the first option, also because of the time perspective, that you often don't have time to have all these extra sessions, or there is we do have to deal with time limitations within treatments. So you can engage again in working memory tasks, or let a client stand and do a V-step while processing. The last thing that I wanted to mention shortly is that how do we actually choose? Because there are all these different techniques, and which process techniques can be applied for which indication. There is not like a very strict rule or very research-driven rule. Besides that, of course, you have the first line of treatments for PTSD, which are by means the first option for treatment. But like in the Netherlands by now, the first option for treatment, we have 6 choices. So what do you pick? This is actually one of the tables that is in the books that we used for this course. And I just wanted to share that with you. You can maybe pause it and read a bit. And I think when it comes to things like this, it is also the treatment option where you feel most comfortable and trained in. And I do think that it is helpful for every therapist to at least have one first line option of trauma treatment in their pockets. A lot of information, but it's interesting, right? And I think the trauma field is still also so emerging. We are learning new things every day. New trauma therapies will probably come our way. And I think that's exciting. And I think it is just like on a more broader level, I think a reassuring idea that, we do face very impactful things as humans on the daily. But by now, there are also a lot of trauma treatments, and most brains are more than capable of processing very impactful things, even things like sexual abuse on their own. And I think that only it shows how great the brain is. But before I'm gonna go on a rant on how cool I think that is, let's end it here for today. If you have any questions regarding the things that I discussed, please drop them in the comment section. If you have things you want to tell the world about trauma, let me know. And in general, I think it might be a wonderful thing that if you have a tip for more starting trauma therapists, to leave them in the comment sections as well. And I'm wishing you a wonderful day. Bye!